And Abhilash is quite familiar to all of us. I think he has been, and his nephro focus is a very innovative thing, and he's doing a great service, and not only doing it for himself, but teaching, and his ability as a teacher has been brought to fore in many of these meetings and in Inform also. So welcome, Dr. Abhilash, and I think ultrasound of the lung was covered last time by Adil, and so that way I think it is better we could divide, and so you'll have all the time to tell us about IVC and other methods and give a holistic view. Thank you. Welcome. You can share your slides now.
Are you able to see the full screen?
Yes.
Very good. Hi, it's a pleasure to be here as usual, and nice to see all the big wigs of interventional nephrology. And congratulations to Dr. Nair, and again, and thanks for your kind introduction. It essentially summarizes my talk pretty much. So without further delay, let's talk about volume status assessment. As the title says, I'm basically trying to say that there is no shortcut, or there is no single organ ultrasound that can tell you everything about volume status and guide patient management. I do not have any disclosures at this time. And the key objective is to provide a bird's eye view of fluid status assessment at the bedside, and to caution against single organ ultrasound. And as Dr. Nair said, POCUS is an enhancement to physical examination. Insonation or using diagnostic ultrasound is in addition to inspection, palpation, percussion, and auscultation. It's considered fifth pillar of bedside clinical examination. And these are all the point of care devices we are familiar with. Knee hammer, flashlight, stethoscope, tuning fork, tape, and all these things. And now sonoscope or ultrasound is added to all these devices. And I stress on this every time. Probably I told this before, but because ultrasound should not be viewed as a separate imaging modality, or something somebody else would do it for you, unless you're ordering some comprehensive exam. You ask a focused clinical question when you examine a patient, when you finish taking history, and you use ultrasound to obtain answers to those focused clinical questions.
Dr. Abhilash, I think you may have to enlarge the screen, because we see the subsequent slide and the view is...
Oh, okay. So yeah, it happened last time also.
Yes.
Is it good now?
Yeah, this is okay.
Okay. And inherently, the sensitivity of conventional physical examination is not that great. It's been long recognized. For example, in this study from 1989, where they looked at patients with advanced heart failure with ejection fraction of 18% and elevated pulmonary capillary wedge pressure, the combined sensitivity of Rales, edema, and elevated JVP were only about 58%. And coming to hemodialysis patients, when compared with lung ultrasound, the sensitivity of lung crackles was only 9%, peripheral edema 3%, and the combined sensitivity was only 13%. In most of these studies, the specificity of conventional physical examination is not bad, because it is designed, or all these classic signs and of physical examination are intended to detect late stages of disease. You might miss early phases of disease when we are using conventional examination. And when do we need to assess volume status at the bedside? It typically occurs in a hypotensive patient, though not always true. For example, in a patient with undifferentiated hypotension without frank shock, you want to know whether to give this patient fluid because the patient is volume depleted, or whether to give this patient diuretic because there is excess volume, or would this patient benefit from vasopressors, as in maybe hepatorenal physiology in the background. And for that, conventional physical examination, it's difficult to discern these individual phenotypes. And fluid status assessment, or more precisely hemodynamic assessment, involves a pump, pipes, and leaks model. Pump means you evaluate the heart, look at the heart, how is the heart squeezing, how is the heart relaxing, if there is something constraining the heart function, such as pericardial effusion. Pipes meaning you look at the back pressure from the right heart, that is inferior vena cava tells you what is the right atrial pressure. And looking at the Doppler of hepatic vein, portal vein, and renal parenchymal vein tells you how are the organs feeling the venous congestion or the effects of elevated right atrial pressure. And leaks are the effects of leaky pipes, meaning you do lung ultrasound and see if there is any fluid in the lungs, that is extravascular lung water. That tells you the effects of left heart failure, if the effect of elevated left atrial pressure. And you look at the abdomen, you look at ascites and bowel wall edema. Those are all the effects of leaky pipes or leaks. So the pump, pipes, and leaks should be evaluated to get a good idea of a patient's hemodynamics at the bedside. And we commonly say, or we commonly think, that nephrologists are experts in fluid electrolyte disorders, right? So we expect other specialists or internal medicine doctors to refer patients to us when they have complex fluid disorders. And some nephrologists are not exposed to POCUS yet. And some who are exposed also say, as nephrologists, if we are able to look at A lines and B lines, it's more than enough. And these two are kind of contradictory statements. So if you want to be expert in something, you need to know how to assess a patient a little bit in more detail. And nothing is perfect, and everything has limitations. POCUS is not 100% perfect. But when you combine that with other things, it gives you more information, and then probably will become experts. And because you already had a good introduction on lung ultrasound, I'm not going to go in detail how these artifacts are formed and stuff. But in general, just to reorient the audience, whenever you're looking at an ultrasound image, structures that are closer to the probe are on the top of the screen, and structures that are farther from the probe are at the bottom. And every ultrasound probe has an orientation marker, and typically, except in cardiac imaging, most of the long axis scans are done with the ultrasound probe marker towards patient's head, and that corresponds to this orientation marker on the screen. So this part of the image becomes towards head, and this part becomes towards feet. And normal lung cannot be ultrasounded unless it's consolidated. So all you see is artifacts. In an air-filled lung, all you see is a bright shimmering pleural line, and that shimmer corresponds to pleural sliding. You have rib shadows on either side because stones and bones don't transmit ultrasound waves. You have a shadow behind them. So whatever space we are looking at is one intercostal space. And here we see these horizontal artifacts, which are essentially reflections of pleural line. These are A lines. So normal air-filled lung consists of multiple A lines. And you see B lines, or the vertical artifacts, when there is interlobular septal thickening. Whether it could be because of fluid, most likely scenario in nephrology practice, or even if the patient has fibrosis or lung contusion or alveolar hemorrhage, in all those scenarios, you still see B lines, even in pneumonia. Okay, and we'll see some examples in the later part of the presentation. So you have a dialysis patient who complains of shortness of breath on exertion and Peter.
Sorry to interrupt, Abhilash. Can you use the pointer? That would be Dr. Manish was in the screen.
This is visible?
Yes, yes, yes.
Oh, okay, sorry about that. Okay, so yeah, we have a dialysis patient with shortness of breath on exertion and pedal edema. So you are the nephrologist, you want to do the physical examination, so you do POCUS. So here we see this is a bright pleural line. We have vertical B lines arising from the pleural line, and these are multiple intercostal spaces. So definitely the patient has B lines. That means increased extravascular lung water. So should we just remove fluid and leave it alone? No, we have to do further physical examination. Never forget the heart. So this is the apical four-chamber view of the heart. Again, I'm not telling you the technique, but this is the comparison image. So in the apical four-chamber, we see all the four chambers of the heart. So this is the left ventricle, left atrium, right ventricle, right atrium. So here is the tricuspid wall and here is the mitral wall. And when we put the color Doppler, you see all the mix up of these colors indicating turbulent blood flow. So most likely we are looking at mitral regurgitation here. Otherwise, when the blood is flowing normally, you should see red color when the blood is flowing towards a probe, and you see blue color when the blood is flowing away from the probe. When you see mixture of colors, it's most likely a high velocity turbulent flow, and it's coming back into the left atrium. So it's severe mitral regurgitation. So mitral regurgitation could be an important cause of lung B lines or elevated left atrial pressure that can be missed if we don't look for it. And why did this patient have mitral regurgitation? And if you closely observe the mitral wall leaflets here, you see some rough, irregular echogenic structure attached to the mitral wall. Here is a zoomed view. So this patient had mitral endocarditis that was leading to mitral regurgitation, which in turn was leading to lung B line. So these sort of cases which require immediate attention can be missed if we don't do multi-organ ultrasound. And say some of you who don't like POCUS might say, I would have easily caught the murmur on auscultation, right? So why should I do a focused cardiac ultrasound for this? I would say we probably overestimate our physical examination skills. Decay in our physical exam skills has been long recognized. For example, this 20-year-old study from looking at over 300 internal medicine residents from USA, UK, and Canada, what they found was they made these residents listen to 12 pre-recorded cardiac events, which were thought to be important by their residency directors. And they gave a test after that. And on this test, you can see that all these trainees scored less than 30% pretty much. So showing our physical examination skills are not great. And these trainees have become attending physicians now. They are teaching medical students and residents. So we can only assume that with time, our skills decay. And somebody might still argue that these are developed countries, maybe in countries like India or other developing countries, we might have better physical exam skills. But again, like you are auscultating these patients in busy wards, ICUs with alarms beeping, and you're in the outpatient dialysis unit, we are all very familiar that you go from station to station and all you hear is all those alarm beeps. So your auscultation, the efficacy will be anyways reduced. Okay, that's a dialysis patient. And we have another patient here who has AKI and has mild shortness of breath. You do physical examination. You are the person who likes to do just single organ ultrasound. So you do lung ultrasound and you see B lines. So there are vertical artifacts and coming from the pleural line. So, and after that, you just said like the patient has increased extravascular lung water. The patient has AKI. Maybe it's the fluid overload component in AKI. And then later you did urine microscopy. You find dysmorphic RBCs. So probably the patient has glomerulonephritis. Maybe we should evaluate for further biopsy if needed. And COVID-19 test was negative. So that's about it. So should we just give some diuretics and start preparing for biopsy? Anything else we should do before that? So if you take a closer look at the pleural line here, it's not smooth. It's very irregular. So, and it's very thick. So thick, irregular pleural line should raise suspicion for some lung-related cause, and probably not all cardiogenic pulmonary edema or fluid overload related pulmonary edema. So then what should you do? You should take a closer look at the pleural line with a linear probe. Linear probe is nothing but a vascular probe or high frequency probe, which lets you assess pleural characteristics. So here you can see that the pleural line is not regular, but it's very irregular. Here is another intercostal space showing irregular pleural line. So what lung cause could be there in this clinical context? So you're having dysmorphic RBCs and irregular pleural line and B lines. You always should think about pulmonary renal syndromes, such as lupus or ANCA vasculitis. And this patient turned out to have ANCA vasculitis, and bronchoalveolar lavage showed diffuse alveolar hemorrhage. So this patient was initiated on plasmapheresis and all that stuff before biopsy. Okay, so A POCUS skeptic again comes and says, I'm an expert in urine microscopy. And in this case, POCUS was not needed. Anyways, I would have gone to lab and done urine microscopy and found dysmorphic RBCs, and that would have guided therapy. Well, first I would say physical examination comes before labs, and POCUS is physical examination. Even before you get the urine sample and run to the lab, you should perform physical examination. And what's the sensitivity of urine microscopy in detecting glomerular disease anyway? So I will leave it up to astute nephrologists, you know more than me. And okay, so we saw one dialysis patient, we saw one patient with AKI, and here is another dialysis patient coming with fever and shortness of breath. Again, you do lung ultrasound, you see B lines, and this pleural line is also slightly appears thick, and here you see some irregularity. And wherever you have this slight pleural line irregularity, B lines seem to fuse and form like a band of light. That's called light beam sign. So these kind of things can be seen in multiple things, like you can see in pneumonia, you can see in contusion and all those things, but it depends on the clinical context. This patient had fever and shortness of breath. So could it be pneumonia? So you take a linear probe and you take a closer look at the pleural line. And wherever area you are seeing that light beam B lines, the pleural line shows definitive break, or you can say it's a small consolidation, small subpleural consolidation. And what could that be? Could it be pneumonia? And okay, let's just start this patient on antibiotics and do the blood cultures and stuff. That's it. No, we have to look at the heart also. And when you look at the subcostal view of the heart, that is looking at the heart from the subxiphoid region. So first you will see the liver on top of the image, because liver is closer to the probe. Then you see the heart. So here is the right ventricle close to the liver, right atrium, left ventricle, left atrium. So in this image here, right atrium, right ventricle, right atrium, left ventricle, left atrium. Here is a tricuspid wall. There is something irregular, echogenic thing attached to the tricuspid wall, like you saw in the mitral wall of the other patient. So this patient had tricuspid endocarditis, and that was leading to the fevers. And this thing is most likely subpleural infarction from septic embolus. So clinical context matters. So it's not just because you see lung B lines. Not everything is about giving diuretics or ultrafiltration. And other POCUS favorite, right? So inferior vena cava. Inferior vena cava is another sonographic application that is commonly used in isolation. Now let's see why it should not be used in isolation. First of all, what is inferior vena cava? It's a big blood vessel that carries blood to the heart. So it's an anechoic tube. Anechoic means black tube that passes through the liver. So this is the liver here, and ultimately joins the right atrium. And this is the head end of the image. This is the feet end, because the orientation marker is here. And you place the probe in the subxiphoid area and look slightly to the right. Slightly to the right because you see inferior vena cava slightly on the right side. And in the middle, there is aorta. And you always want to make sure that the hepatic vein is joining the inferior vena cava, and inferior vena cava is going into the right atrium. Because on some images, you can confuse aorta with inferior vena cava. And what does it do? So it's just a tube that is connected to the right atrium. So IVC reflects pressure in the right atrium. So if the inferior vena cava is small in diameter and collapses with inspiration, that indicates low or normal right atrial pressure. And what is big and small? For standardization purposes, echocardiography literature uses 2.1 centimeters as the cutoff. So if the IVC is less than 2.1 centimeters and collapses more than 50% during inspiration, because during inspiration, our intrathoracic pressure reduces and the vessel collapses. So that's considered normal right atrial pressure. In this image here, the IVC is pretty small. It's like half centimeter maybe, and completely collapsing. This indicates normal or low right atrial pressure in the appropriate clinical context. That's another thing. Just because somebody's IVC is small and collapsible, it does not mean it's abnormal or we have to give fluids. This exact image was obtained from my cardiorenal clinic patient, and the patient was doing fine and the creatinine was stable, so nothing to be done. Don't ask this patient to take salt or water, or don't admit the patient to give IV fluids. And in this example, the IVC is big and plethoric. meaning it's more than 2.1 centimeters, it's barely collapsing with inspiration. So it indicates high right atrial pressure. If you have high right atrial pressure, that's telling you that there is increased resistance to venous return, and you probably should not give fluids to this patient. And at the same time, should we give diuretics to this patient reflexively just because IVC is big? Not necessarily. It again depends on the clinical context. This image was also obtained from a nephrology clinic patient with pulmonary hypertension. So when somebody has pulmonary hypertension, there is IVCs always big. And if the kidney function is stable, you don't want to do anything unless basically the clinical situation warrants. And it's a common myth that inferior vena cava focus can be used to determine fluid responsiveness. In fact, that's propagated by multiple studies looking at this endpoint. But IVC is just a indicator of right atrial pressure, right? And when we are saying fluid responsiveness, we are saying you give some fluid to the patient and the patient is able to mount additional stroke volume in response to the fluid you gave. And it's a left-sided parameter. So for that, you really need to measure the stroke volume at the bedside, which can be done using focused cardiac ultrasound. I'm not going into that, but the point is, you look at this Frank-Starling curve, and central venous pressure or the preload is on the x-axis, and cardiac output or the stroke volume is on the y-axis. And when somebody is on the steep portion of the Frank-Starling curve, most likely the patient will respond to fluids, and likely the IVC will be small and collapsible. So you can argue that a small collapsible IVC is associated with fluid responsiveness. Fair enough. And when somebody is on flat portion of Frank-Starling curve, the patient will not likely respond to fluids, and this will be more likely associated with a plethoric IVC. Again, you can argue that a plethoric IVC is probably not associated with fluid responsiveness. That's also fair. But in the middle ranges, IVC cannot predict responsiveness to fluids. That's one thing. And you don't know in which part of the Frank-Starling curve a patient is. And every patient's curve can be different depending upon the preloading conditions, afterload, and cardiac contractility, that is underlying cardiac function. So IVC should not be used to determine fluid responsiveness. And what will you do based on fluid responsiveness? If you know a patient is fluid responsive or not, it shouldn't really change the management in most scenarios, because exhausting fluid responsiveness is never the goal of therapy. Just because somebody is fluid responsiveness, would you want to give the patient fluid? No, because fluid responsiveness is physiologic. Everybody should be fluid responsive. And isolated IVC ultrasound has several pitfalls. The common thing is you can easily confuse this with aorta. In this example, we are looking at the IVC from the lateral aspect. Initially, I said we look at IVC from the subxiphoid view, right? But you can also look at IVC from the lateral aspect. And it usually helps when somebody has like a lot of distended abdomen or gaseous abdomen. And the first thing the probe encounters here is the IVC. So the IVC is on the top, and obviously liver is on further top. And aorta is farther from the probe. So aorta is somewhere here. And both these are anechoic tubes. So it's important that you don't confuse IVC with aorta, especially if the IVC is so small, you can easily think aorta is the IVC. But you always make sure that the hepatic vein joins IVC, and IVC goes into a beating structure that is the heart. And this can happen even for experienced users. If the patient's body habitus is not so great and you are using some handheld machine with suboptimal image quality, it can still happen even with experienced users. And so where do you measure the collapse of the IVC? We said IVC collapses during inspiration in spontaneously breathing patients. So ideally you want to do it below the hepatic vein IVC junction, somewhere here, maybe a centimeter below that. I mean, you can say 3 centimeters from the IVC right atrial junction or whatever. I just remember, just look at the hepatic vein and go slightly below that and measure the collapsibility. That's where IVC collapses the maximum. And in this image, is this collapse? No, because wherever you are seeing the approximation of the IVC walls, that's at the IVC right atrial junction, where you have diaphragm. Diaphragm always exerts a pull there. So that should not be counted as IVC collapse, which some novice users can do. In reality, this IVC is pretty plethoric or engorged. So it's more than 2.1 centimeters. And in this area, it's not at all collapsing with respiration. And also one thing you have to keep in mind is it's in spontaneously breathing patients. Your intrathoracic pressure goes low during inspiration and IVC collapses. But if the patient is already on mechanical ventilation, getting positive breaths, it does not collapse during inspiration, but rather maybe distends during inspiration if there is enough space. And it also depends on the strength of breath. Every patient is different, and you have a 80-year-old old woman versus 30-year-old heavily built muscular man. So their strength of breath differs. So, and it also matters. So because we measure the collapsibility and we ask the patient to take a sniff or take a deep breath. It's just to standardize the breath, but everybody's breath is different. And also when you're following IVC with you give some diuretic therapy or ultrafiltration, you're monitoring IVC. As the patient gets better in the hospital, the strength of breath might improve, right? So it's not a real good comparison just to follow IVC. And also IVC is frequently subjected to cylinder effect when you're looking at in the long axis view. So IVC is a 3-dimensional structure. We are trying to slice it through the middle of the vessel using a 2-dimensional modality, that is the ultrasound. If the beam passes through the middle of this circle or the middle of the cylinder, you get the maximal diameter of the IVC. But if the beam passes through a periphery of this circle, you get falsely low diameter of the IVC. That's called the cylinder effect. And to minimize the cylinder effect, it's always good to look at IVC in short axis. So here is the short axis correlation of the IVC, anatomy and short IVC. So your ultrasound probe is here anteriorly. So this is anterior, this is posterior, and you have the liver here. So all this thing is a liver tissue. And here is a vertebral shadow because vertebra is a bone. So you have shadow behind that. This round structure is the aorta, and this is the inferior vena cava. And these tiny anechoic things are hepatic veins going towards IVC. There are 3 main hepatic veins. And IVC generally is more elliptical in shape when you look at it in cross section, and it's usually smaller than the aorta. Aorta is more roundish structure. And other pitfall is that even in short axis, in general, our thinking is arteries are pulsatile and veins are not. I put this picture up on Twitter and asked, like, what is this? And only about 60% of the people got it right, and rest of the people thought it's some kind of artery, whether it's aorta or hepatic artery or some superior mesenteric artery, just because it's pulsatile. But otherwise, if you look at anatomic correlation, it's like really good anatomic correlate with, here is the IVC, and you can even see hepatic veins going into the IVC, and this vessel is pretty much inside the liver as opposed to aorta, which is outside the liver. So the blood flow in the IVC is actually pulsatile in normal state, and it's exaggerated when somebody has hyperdynamic circulation, such as volume depletion or tricuspid regurgitation and so on. And in transverse IVC, so this IVC is pretty normal. It's small, it's elliptical, it's almost completely collapsing with each breath. And this IVC is huge. This was obtained from a patient with chronic pulmonary hypertension and tricuspid regurgitation. Aorta is here, and IVC is big and round with all these hepatic veins. These hepatic veins are probably bigger than the IVC here, and the scale is the same in both the images. So in general, when you see a round IVC in the short axis, it's probably not a good thing. So because we said you should see IVC in the short axis view, our trainee tries to get only the short axis, just avoids a long axis view. So it gets this image and says IVC is plethoric here. Yeah, I know this is IVC because the hepatic veins seem to be joining the IVC and it's pretty close to the liver. And so this IVC is plethoric. This patient probably needs diuretic. This patient has AKI. But in reality, what was the trainee looking at? So this is the subxiphoid view, like the other view I showed you with the vegetation. So if you look at it closely, right atrium, right ventricle, left atrium, left ventricle. So whatever this part is the right atrium of the heart, confused with inferior vena cava. This small thing is actually the inferior vena cava with hepatic veins joining inside. Again, take a close look here. This is the right atrium. And this is the inferior vena cava, that small thing. So especially these kind of mistakes happen when the IVC is small. So when the IVC is small, we might not even be like able to recognize that at first glance. So you might confuse that with other structures such as aorta or right atrium. So you confirm that in the long axis, you can see that the IVC is very small and completely collapsible with respiration. So one view is no view. Always try to look at IVC in 2 views. And sometimes you can have false collapse. So this IVC is, say, about 2 centimeters or so in diameter, but it appears to be completely collapsing. But is it really collapsing? It's not, because what it is doing is actually as the patient is moving, the liver is moving from side to side, and the ultrasound beam is moving out of the inferior vena cava. You can see that in the short axis view. So this thing is the IVC, and initially the ultrasound beam is passing through the IVC, right? And as the patient takes a breath, the whole image is moving towards the other side and the beam is just passing through the liver. So whatever collapse you are seeing is just because of the movement of the IVC rather than being a true collapse. That's another common mistake in clinical practice. And here is a nice example showing both kinds of false collapse. So here you see diaphragmatic pull, the initial image I showed you, and here is a false collapse because of the movement of the beam out of the vessel. And sometimes IVC can be confused with other structures such as duodenum. So duodenum is also a tube that runs parallel to IVC, right? And normally it has some gas and stuff, and it's not distended, so you don't pay much attention. But when it is dilated, this image was obtained from an ESRD patient with admitted for diabetic ketoacidosis, and the patient also had some gastroparesis, or ileus. So this was a distended duodenum, and when it's filled with fluid, it appears black. So it can be confused with a vessel. So you always fan the probe and find the right structure that you want to. Again, if you put Doppler on this thing, it won't light up. So it's an easy thing to do, but you don't always do that. So it's always important to make sure you're not confusing with other structures. And particularly in suboptimal images, you can confuse caudate lobe of the liver with IVC because these are also side by side, right? And in suboptimal images, your gain or the brightness of the ultrasound image is not appropriate. This appears just like some other vessel. And you can say this is IVC and this is aorta. And obviously the caudate lobe is not going to collapse and it appears big. So you can say it's plethoric IVC when it's otherwise not. So many things can happen. And finally, a very few cases again. So a patient with intradialytic hypotension and mild shortness of breath. So the nephrologist does lung ultrasound and it shows predominantly A lines. So just because we said we don't want to just rely on single organ ultrasound, this nephrologist is good and does IVC also. So lungs showed A lines. That means there is no extravascular lung water, at least not significantly. And the IVC seems to be relatively dilated. It doesn't seem to be collapsing. The doctor says, okay, the patient has some volume, but maybe you are pulling too much fluid. Just reduce the ultrafiltration rate and leave it alone. Is that it? And actually that helps. I'll show you why. But you need to look at the heart also. So if you look at the heart, this is a long axis view of the heart. And the upper chamber is the right ventricle corresponding to this. Here is the left ventricle, and here is the left atrium, aorta, and this is the descending aorta. And this black structure here on ultrasound fluid is black. All this black thing is the pericardial effusion. This is the 4-chamber view, left ventricle, left atrium, right ventricle. You have all this black thing surrounding the heart. This patient had pericardial effusion. So what happens when somebody has pericardial effusion, even if it's not large or the patient isn't over tamponade, during dialysis, we are removing fluid from within the heart, essentially within the intravascular component. So the effect of the extrinsic compression by pericardial effusion is exaggerated. So even with moderate sized effusions, the patients can go into tamponade. That's very important to note. And also, like if you really pay close attention in this image, just not looking at the IVC, here is the beating structure, that is the heart, and there is some gap between the liver and the beating structure or the right atrium. That's actually pericardial effusion. So if you really pay attention, you can even recognize pericardial effusion even from the IVC view. Here we have another patient, AKI patient in ICU, and the patient had CHF and all that. The patient was diuresed in the previous days, but still the patient was in positive fluid balance. So anyway, so because of the AKI, you wanted to initiate on dialysis. You write for 3 liters during the session. And the nurse comes and tells you the patient is hypotensive, the blood pressure is in 90s. Do you really want me to pull 3 liters? Here comes the doctor who doesn't do POCUS and says, okay, patient was diuresed a lot for the past few days. Maybe the patient is dry. Just don't do any UF, just do some dialysis for clearance. But you really need to do some physical exam, right? So you did physical exam and the IVC is plethoric. That's high right atrial pressure. How come the patient is over diuresed? I mean, it's possible rarely the IVC is chronically distended, but that's not the point here. Then you look at the heart. This is the short axis view of the heart. And when you slice the heart this way, normally you should see a left ventricle that is round and a semilunar right ventricle. And in this case, You see left ventricle and right ventricle, but the left ventricle is not round. There is interventricular septal flattening because the RV is full from fluid. So when RV is big and full, it's going to push the interventricular septum towards the left ventricle, and that compromises the left ventricular outflow, and that could be leading to hypotension because of the reduction in the cardiac output. And this is one scenario where giving diuretics or doing ultrafiltration will actually improve blood pressure. So low blood pressure does not always warrant fluids. And in this case, giving fluids to this patient would actually worsen patient's clinical status. That's very important to note. And after 12 liters of ultrafiltration, I always put patients on CRRT. CRRT is my favorite. You can see the IVC is still big. The patient had pulmonary hypertension, but the LV has become round. This is essentially proof of concept that initially the blood pressure was low blood pressure was because of this interventricular septal flattening. You can also argue that RV gets big in pulmonary embolism, and interventricular septum can also be seen in pressure overload and stuff. But again, clinical context is very important. You always compare with prior imaging. You see, is this patient likely to have more pressure overload, or does this patient have DVT, and are we looking at pulmonary embolism or stuff? And finally, we have a cirrhosis patient with acute kidney injury. Because the guidelines say give albumin to exclude pre-renal injury, should we just blindly give albumin in all the patients? No, do some POCUS. So did you examine the patient, or did you do POCUS? So okay, fine. I'll do some IVC ultrasound. This patient was on mechanical ventilation, and this liver looks too bright because of cirrhosis and underlying fatty liver and all that. I mean, cirrhosis livers are relatively difficult to image. I mean, liver is easy to image, but finding vessels can sometimes be tough in this patient. But anyways, like this guy found IVC in transverse axis. It doesn't really appear big, circular, or plethoric. And the patient is on mechanical ventilation. You don't expect it to collapse so much. Fine. So IVC doesn't look too horrible. So shall I give albumin now? No. Look at the heart also. Fine. I look at the heart. Here is a short axis view of the heart. Here is a LV and RV. LV seems to be squeezing very well. So probably it's hyperdynamic. And here is the apical four-chamber view, LV, LA, RA, RV. And the LV contraction is very good. There's a little bit of pericardial effusion, probably not so unexpected in a patient with low albumin having some ascites and all that. So now this guy says, okay, I looked at the heart, LV was hyperdynamic. It does not change my management. Let's give albumin. But you missed another thing. You should look at what is stroke volume, right? So not every hyperdynamic LV is equal to volume depletion. In volume depletion, LV is hyperdynamic because you don't have much volume, and LV is trying hard to pump out more blood. That's why it's hyperdynamic. And you can have hyperdynamic LV even in severe mitral regurgitation. And you can also have hyperdynamic LV when there is vasodilatory state and hepatorenal syndrome patients, or just cirrhosis pathology is associated with significant splanchnic vasodilatation and hyperdynamic circulation. And I'm not discussing in detail the stroke volume assessment, but this number here, 30, tells you it's a surrogate for stroke volume. Normal value of this number, called VTI, or velocity time integral, is about 18 to 22. In this case, it's 30 with an estimated cardiac output of about 10 liters. So this patient does not have volume depletion. If this patient was volume depleted and subsequently had hyperdynamic left heart, your stroke volume should be low, or the cardiac output should be low. But in this case, with a cardiac output of 10 liters, why should you give albumin? Like, what are you trying to increase it to? You want the cardiac output of 20 liters? It doesn't make any sense. So you ideally should want to start this patient on some vasopressors. And the last slide. So essentially, hemodynamic evaluation is not single organ evaluation. You need to have knowledge of multiple things. You want to be evaluating left ventricular outflow tract Doppler. For stroke volume assessment, you want to know how is the left ventricle relaxing. You can do that by mitral Doppler. You want to know how is it relaxing because sometimes you have B lines in the lung, right? And you can say if you have irregular pleural line, like we saw in the other cases, it might be pulmonary in origin, but that's not always so easy. Some patients can have pulmonary disease underlying. You can still have cardiogenic pulmonary edema. Who says you cannot? So in that case, you want to look at how is the heart relaxing and measure those parameters and see if that's cardiogenic or not. And you go back and you look at right ventricular outflow tract Doppler, tricuspid Doppler to look at the pulmonary pressures. And you go back and do the hepatic vein, portal vein, renal vein Dopplers to look at venous congestion. And you also assess deep vein thrombosis. Don't think none of this is related to nephrology. Everything is related to nephrology practice and even DVT evaluation. So your patient with nephrotic syndrome is predisposed to having a clot and subsequent pulmonary embolism. And you might be wanting to do this thing in the outpatient dialysis unit also. And finally, ultrasound, this machine doesn't have any brain, so use your own. It's like stethoscope, like it's a common joke in medical school, right? They say, your professor will ask you, like, what's the most important part of stethoscope? And they used to say, it's a part in between the earpieces, that's your brain. So it's the same thing with ultrasound. So thank you so much. And yeah, I mean, I think exactly 39 minutes, 39 seconds. So I can take questions at the end. You can go ahead with the other presentation. Thank you.